Hi, everyone, and thank you for joining us for our virtual health event in collaboration with UC Health. I'm Hannah Schrepfer, representing the Highlands Ranch Community Association, and it's a pleasure to have you all here tonight. We truly appreciate your presence as we delve into the topic of managing back pain. We're also thankful for the support of UC Health Highlands Ranch Hospital, our valued community partner in making these events possible. Before we get started, I would like to go over a few housekeeping items. We are recording this webinar and we'll send out the recording to you via email within the next few days. During this webinar, your microphones will be muted. To ask questions, please type them into the Q&A chat box. This can be found in your control panel on your screen. We'll save the questions for the Q&A portion towards the end of this event. Our presenter this evening is Dr. Laker. He's a physical medicine and rehabilitation specialist from UC Health. Now, without further ado, I'll pass the time off to Dr. Laker.
Thanks, Hannah. I appreciate you. A great pleasure always. Like Hannah said, I specialize both in. I've been in years, if you add it all up. University of Colorado. My two daughters. I have twin 9-year-olds. Yeah, I've been a hospital since it, and now we've grown it. Dr. Michelle, our nurse practitioner that operate at Highlands Ranch community. And so I'd urge you, if you have questions, I can cater what I'm Q&A, but hopefully I think about conditions that probably are lucky enough to live long. And back pain is one of the, there's actually some really we should treat it like wrinkles to completely change. So my official clinical affairs to our residents about thinking what are the usual which are part of your back pain. Those three are of age. Now there are autoimmune disease. As a patient myself, worst when you start to have easy to rule these things in or to determine what's happening with you. To move forward, back pain treatment and insert is the boogeyman of spine care. So I thought we'd approach. My business means, probably a duck. Things that cause back pain. Flags, we call them red, would suggest that you maybe need. I talked about some. They may help you understand what. I also want, as a patient, to understand and what imaging is not. Maybe a few common indicates that you probably had some sunshine playing tonight. Model. Is this back pain acute? Or is it chronic? Subacute lives in that net Is it traumatic, meaning it happened? Does it purely in your lower back? Meaning that there's hip pain that goes, etc. And we'll talk about the most common thing that we see: pain, just given the nature. 40 to 50% of our patients. This is what your back looks like. Pardon my my Adobe Photoshop version. Series of segments: L1, L2, L3, L4. Those yellow, what you got is moving down the center, and then that branches off that go down into your leg, which really means, in general, talking about there is pain that radiates hamstring and calf in your body. Each area belongs to a different nerve root. Then typically you'll into the hip, nerve root. Then you get those of you that are currently dealing. Think of it that way. One of these later on in the conversation. Or one of the things that I end up paralyzed, your spinal cord end, and then the thecal sac much lower down in your. So it's extreme that I'm going to talk about tonight. Paralysis happens with car accidents, but there are some rare conditions. Weaken the bone. Just so you all know which injections, and we offer injections to help. What are they good for, and what are they? So epidural steroid injection, generally done for nerve root pain. So if you oftentimes are more axial pain, more branch blocks are the little joints in your back that I'll go. Radio frequency ablation. You use temperature around the nerve and it shuts off. It's a great procedure. It can last on average about. The last one is sacroiliac joint. Your pelvis to your sacrum. As we age, can become pain. Buttock pain. Backside hurts. Dose it to confirm treatment to make the pain not hurt. These are the segments. Seal joint or facet joint. So it's that articulate. You can think of it just like in critic. They can, when you're sitting unsupported, you stand up and you say, my back is your facet joints. These are the nerve roots. Those nerves. This is one of the easy. This lay a needle point, essentially go low back pain relief for long. This is a look like on the outside of it, annulus fibrosis, and on the inside is the gel. Only a third of that disc. It can hurt, especially generation, especially if you're a young. But in general, donut go away. Height over the course of meters of lost height across, lost an inch or two in height. The most common. Lumbar segment is times when we're talking in clinic causing my back pain. But unfortunately, with articulations are you've got facet joints on either side. You've got the ligaments. The things that we know, eventually it starts to analogy. If that all of a sudden you're kind of pulling to differently, and then that where, so it's not uncommon to slowly blossom over, but that's typically over. I cheat when where your back pain is coming from. On the top of your iliac crest. And you draw a straight line. The level in between the L of that, you're probably looking at that around your belt line. Palpate your T12, but so this is about 50%. Folks ask, well, just on, it's not particularly active. Is it L4? Is it L4? This is some help us tell which nerve root is L4. Often patella. That's that can't be undone. Reflexes don't come back once you're 25 playing baseball. A lost reflex. A straight leg raise test is one. What it's doing, you're laying, bend your leg up towards, radiating down below your nerve roots, and it helps to your, or is it coming just, and in general, whereas disc hernia and a little bit more effort. This is, if you're wondering what it looks like, that nerve root, and what we're doing is we're really trying to put tension in that nerve root to and help us increase our. This is another one you in your thigh that will do this examination, that problem for people to have tight hip flexors, psoas, your rectus femoris. One of the things that we often send people, if you spend all day sitting, in the front of your hips is going to be really tight. That lower back. So one of some of these correct. I like when it comes to the which is in general are very benign. get better on their own. Over-the-counter medication, practice, but now the difference here is at TSA, and my usual recommendation first, if you're having 1 to 2 weeks walking programs and it's probably worth talking to those of you that have prior nerve injuries. Wise thing to do, just like TSAs. Sometimes you need 2. That's what we're trying to do with this. These are some of the red that we think about up. So 8 about fracture, compression fractures in the past. Female gender density is a risk factor. Is an independent risk factor. Personal history of a higher degree, and you have a history of scary things like unexplained night sweats. Now, some of you have some of these. 80% of my patients will have it, but only about 1 out of all. So the red, what we do with you, but about what's going on with your body. Red flags, alcohol, use of particular over time, fever in recent. So even if you've had fever recently and knew what could be causing your pain. Bowel or bladder dysfunction control is an emergency department for. Saddle anesthesia means and progressive weakness. Little things like fatigue, foot, you have drop foot, the weakness. Those are all things. Now this will lotions and lotions as it relates is an area that's fraught. People that have do things to you that maybe you don't. NSAIDs and muscle relaxants that it in that slide you see a 0.4 decrease in relaxants can decrease it. You reserve these not like PT that are failing those first of people with acute it's really important. Goes away within 2 weeks. So then with severe assurance and education, prescribe anti-inflammatory or painkillers, not narcotics. And then if it's then we look at it's hard to the PT and now think like lower back pain, wanted to focus on uncommon, but one for back pain is increased education. And is not other interventions and what evidence they NSAIDs relatively low. I'm going to point out an interesting that kind of follow some of the opioids do improve pain, and they have so many side effects that the risk for chronic lower back pain. This may have heard of the analgesics. So you start small. That's in things to something strong like Norco, which is latter probably doesn't work for lower chronic low back pain patients. Opioid dependence. And I'd love to talk about it. So these are some rheumatologic concerns. You potentially have these. Possible autoimmune younger than 45. Mechanical, it's like worse than the family history of your mom. If you have, I bring this up, it's very challenging to talk about. But if you have, my backside hurts, then my communicated to your doctor, only have back pain. Means things like eye symptoms, oral symptoms, positive response. Autoimmune diseases do. What I put about acute lower, 90% of people will have, 30% of the population will have improve between 2 to 8, an 85% chance. Not true to say that back pain, a lot of times when we talk to patients to come individual, not for the between 2 billion with when you account for loss, estimated to be about 30. Okay. I know as to hear this, but a lot cause really difficult to pin down all of it. Recover to make a clear better at this as a chronic pain consistently, right? A home run. Etiology at the time of the visit. This is useful. I know to people, but 7 to 8 issues, compression fracture, etc. The clinic. It's not the when you start feeling low back, scary thing. So it's useful. Pain is mandatory and sub is necessary when your back's this is a can understand what's happening. So in general, than 6 weeks, no prior intervention. The answer is the x-rays for this. Done in most of the clinics that my patients are over that age. Red flag as it's defined by the. One of the areas that's is MRI for acute phase of lower back. Different than getting an MRI. You have a rotator cuff tear. Lower back, which are extremely the cause of the lower back pain. Very best to hold off on failed some of this that you haven't gotten better with. Need to do these, they don't help you decide what to do. Rare, these are more the conditions. Back pain, and MRIs may not subacute or again, no prior, no. Now, when you get into this, following 6 weeks of medical, ended at that point. Well, they're kind of a 1-2 punch. Discs and nerves, and it help us decide if we should do one of these. I anticipate. I'm happy to answer those. Research. Often probably. Critical that you hear this the same way is probably the problem that is natural. Degenerative disc disease happens when the discs lose some in the spine, start to lose some of the flexibility. Discs start to bulge, but it is critical. Equal pain. Above about the age of 40 or MRIs. MRI findings do not exact same amount of degeneration. So people without back pain. So, but they are not. Help us with your help. Fun diseases that I diagnosed but commonly seen on Strip's disease. This is in your back, the things that you as you age, those spine each other, and they can cause your spine. They show up a lot. Necessarily pick these up. That this may be an option. Clinic. That one or more of you have. There's lumbar radiculopathy involvement that's called pulposus. Stenosis causing lumbar. Different cause. It's radiating lower sensory changes. But it's very painful. People will improve on meaning about somewhere between that year. So herniated disc. You have a However, the injections and PT you through surgery, and the surgery home run. They will me surgery feeling great, and like at Highlands Ranch Hospital, Dr. Patel and Dr. Will. So this radiating pain with weakness, with sensory, plus some sort of tie the symptom. Spinal stenosis fever is a little different. A disease of 60, 70, and beyond. Risks are like a 20-year-old. I'm overgeneralizing, but these are mechanical pressure on the nerve root, but from a different. These are degenerative changes. That's thickening. Pain, extremity pain. This is a really tangible determine what your problem is. We can't accurately test disc, which is treated drastically different. For most patients, it can be well managed. This also work quite well. Fusion, and I'm happy. That can go along with it. To progress slow stenosis in a 90-year-old, mean you'll have more symptoms. The biggest predictor for spine 10 years, your future 10. My mouse, but if you cannot, a big disc herniation, lumbar spine, one to the side on your cut like a loaf of bread. These little black dots, that disc is, so this patient is very hamstring in their calf, doing toe raises, so coming up on lose, if you remember that slide. So when we see all, guarantee this is what the problem is. For the initial apathy, rest, plus or minus oral thing for you as an individual. Useful this diagnosis judiciously and brief for this problem. It helps getting the pain out of your leg, lower back. Another anatomy lesson. Are one of the most common in the country, and intervention that's prescribed of bad things happening. It's about 1 or so. So twice. So infection, allergy, spine. We've done a lot of things to patients in general, somewhere between 3 and 5 problems is fairly sensitive. Problems like herniated disc, but for times we're trying to use the exposure to steroid. So needle, and you're looking kind of down the barrel of that needle. For those of you that birth, this is the same approach. A small amount of steroid and anesthesia that causes you to have the pain. On the right-hand side, you can contrast the material that we use place and not. I want to give oral steroid injections under X-ray guidance. With these are not the world's things that go bad in spine. You to see someone that on how to do these things, and I would never advise without some sort of image with bleeding with other types. So surgery really does have its place, especially if weakness are progressively getting that can injectomy, where you pull out just, or something that's a little more involved, removing other bone, and now being like a circle like this. The way of getting rid of that is to remove the edge. Then you're dealing with an enclosed structure around the option. If you have, doesn't require any fusion harm. About facet joint pain is that's an, I don't want to belabor the point, but this. So you can read this. Two types of local anesthesia, the nerve temporarily if your back pain went away. 80% improved. See ablation. Unnecessary procedure. Frequency ablation procedure. It usually requires, so two of those hypertemporal procedure that's giving you some long last, based on the evidence that's out there, procedures and insurance companies and kind of what they people away from getting unnecessary. So the image, the needle will contrast on each of those, help with the pain. Duration, this 10 months. It does need to be permanent procedure. 10 to 16 months. Slam dunk. Those of you that have been around this for a while, injections into the facet starting to become less favorable, may not be particularly helpful being ordered over the course of time. Stop my screen. You guys kind of guide me on what questions. I'll kind of say this. One of the things that's out there, you've all probably heard this. I'd be remiss if Kathy were on this call and I didn't tell her. Bed rest for back pain is absolutely terrible. If you are on strict bed rest for an episode of acute lower back pain more than 24 or 48 hours, you are most definitely doing yourself more harm than good. So if you feel like you need that level of care where you just can't get out of bed, go see somebody sooner rather than later. Otherwise, some of the consequences of the bed rest can be more dangerous than the back pain itself. Okay. So Hannah, I'll kind of take a crack at Mr. Blue's question here.
Okay, that sounds great.
So fusion from L4 to S1 means that there's hardware, so screws that go into the L4, the L5, and the S1. And then it's got rods that hold those screws in place. Those fusions are done because once we surgically take out a lot of bone, we have to put something back in there to stabilize the spine. So the dull ache across the lumbar area, there's a couple things that kind of come to mind, Steve, when we look at that. One would be making sure that the hardware has not failed. That's very uncommon, but not never. It's easy to determine just with x-ray. The other thing is very commonly with that kind of fusion, people get sacroiliac joint pain, and that lower buttock pain radiates up into the back in about 25% of people. So it feels like back, and it is your back pain, but it's coming from a lower back pain. And then the other one you get would be problem at the level above the fusion, which is called adjacent segment disease. Adjacent segment disease is the thing that you hear when your friends talk about, I had a back surgery, and then 5 years later they had to extend the back surgery, and 5 years after that they had to extend it even further. That is code for adjacent segment disease. The number that we quote, it's not perfectly accurate, but it's easy to remember. About 15% of patients 15 years after their initial fusion will have adjacent segment disease and need an additional operation. All right. What percentage of lower back fusions have IVH? You mean like intraventricular hemorrhage, Diana? Diana, my question for you is, tell me, I want to make sure that I'm answering your question right for IVH. Spondylolisthesis treatment. So spondylolisthesis is typically there's two causes for it. One's a fracture that happens in two of the small bones in the back that usually happens in adolescence. So when those bones break, the front half and the back half of your spine can separate and they start to move forward. So if you remember that picture of the bones stacked right on top of each other like Legos, spondylolisthesis is one is moved forward. So the non-operative treatment for it is treating the symptoms. If you have a lot of lower back pain, we move towards that ablation type procedure. If we are having a lot of leg pain, we do the epidural injection procedure. If you're somewhere in between, physical therapy for core strengthening is really useful. And we always do that before we do any of those ablation procedures. But really interestingly, radiating leg pain from spondylolisthesis has about a 96% cure rate with spinal fusion. So it's one of those operations that works really, really wonderfully. I've joked with our residents, if I could pick a problem, having radiating pain due to a spondylolisthesis, I'd probably take that one because it is very surgically fixable.
All right, Dr. Licker, it looks like we got a response from Diane.
There it is. Sorry. Intraventricular hemorrhage. For a lumbar fusion, I don't have any good answer for that one. So intraventricular hemorrhage would be like a brain hemorrhage during that. That would be more of like one of the risks of just general anesthesia. And I'm sorry, I can't give you a good quote for that. And I apologize. There are more questions here and I didn't see them yet. So let me go through. All right, Jill Parrott, what do I think of inversion machines? Really critical that you know what your other risk factors for. High blood pressure is a concern for inversion machines. Making sure that you know how to safely do it is also really important. In general, if you're going to do inversion machines work for large populations? They tend not to. So if you have 1,000 patients and you prescribe inversion machines, they tend to not be better than placebo. But individuals do very well with inversion machines. So I've often recommended people start easy, with a 20 or 30% inversion, and then work up from there. But really, really critical to make sure you don't have any other problems that can cause you, stroke. Other kinds of heart and cardiac conditions can be worsened by going upside down. Lori, is most mid to low back pain related to weak core strength? I'm going to kill a sacred cow here a little bit and say no. It's one of the ways that we address lower back pain, but it's not oftentimes on its own the direct cause of the lower back pain. Some of the cause is not under your control. Some of those degenerative changes, some of the wearing down of cartilage, but the core strength and the flexibility that I mentioned before allows you to be in more proper alignment and more neutral alignment so that you're not putting so much stress on some of these pain-provoking objects. There's probably increasing evidence that's coming out that suggests weak, quote unquote, weak core strength or great core strength is not associated one way or the other with it. SI joint fusion success for pain relief. So there are a couple really great minimally invasive sacroiliac joint fusion. We use SI bone, and Dr. Patel, my colleague at Highlands Ranch Hospital, is one of the developers of that procedure. So it's 3 very small dowels, essentially like triangular shaped columns that go into the sacroiliac joint. I want to say it was 80+% pain relief, provided that you go through some diagnostic workup first. So we try sacroiliac joint injections under X-ray, like with me. Then oftentimes we'll do them with CT scan for confirmation. Then we'll do it again for additional confirmation. And if those things are working, but not giving you long enough pain relief, then we'll recommend sacroiliac joint fusion. Let's see. So what do I recommend for someone with herniated discs in the low back who cannot sit without pain? Probably a more complicated answer than you want here. We probably have to talk through it in some detail about exactly what's causing the problem, what's been tried. Are they, multiple herniated discs, or are they more of that degenerative changes routine? You cannot sit, and then that cannot sit without low back pain tends to, for me, point out facet joints, especially if you're kind of in that unreclined position. Julie, I'll try to answer this one. So ablation is not done for nerve root compression. Ablation is done for arthritis in those facet joints. So oftentimes people will have a combination of 2 things. They'll have the facet joint arthritis, which is treated with the ablation, on top of spinal nerve root compression. The ablation is such a low risk, highly successful procedure. Oftentimes we'll start with the ablation because it's, for lack of a better word, low-hanging fruit. Like, we can address that pretty easily and rapidly. Whereas spinal nerve root compression, the only definitive way to decompress those nerve roots is surgery. We do, for nerve root compression with radiating arm pain, we'll do epidural injections to control some of that arm pain. Anterolisthesis is the same option as that. Spondylolisthesis. Anterolisthesis just means that the movement is forward. Retrolisthesis is back. Lateral is side to side. Spinal cord stimulator device implant for pain. Really complicated answer. I'll try to answer as best we can. Spinal cord stimulator devices they start off with semi-permanent and then move into permanent implants that go in your spinal canal. And they send a non-painful electrical stimulus through that wire. And your brain can only keep track of so much information at once. So the spinal cord stimulator doesn't allow you to process pain the same way you would if you didn't have it. It is almost always used in patients that we have not been able to make better with less permanent solutions. So things like injections, therapies, acupuncture, chiropractic, all of that stuff that I mentioned. When that's not working and surgery is not working, then we start talking about spinal cord stimulators. The very good news about spinal cord stimulators is you can do a temporary trial of them. So you put that catheter in for about 72 hours. You report back to the person doing that procedure, and then if it works, then you can move forward with the permanent placement. So on the not so positive side, we tend to see the improvement that works very clearly in the first 6 months to a year with spinal cord stimulator placement tends to wear off after about a year. So it's something to really, really talk with your providers about the wisdom of going forth with a spinal cord stimulator. DA, I probably know there's more to your particular story. There's lots of reasons to use spinal cord stimulators outside of what I just mentioned, but that's the most common time that I use them in my practice. Okay. Less painful annular tear. So annular tears are the tears in between that crisscrossing fibrous shell on the jelly donut. Let's see. Completely stiff and couldn't move after months of PT, still weak on one side, at risk for another tear. prevention is kind of the holy grail of spine problems. There's not good evidence that anything can prevent this. The best that we've had is taking good care of your body otherwise, making sure you're flexible, making sure you're strong, making sure you're getting good cardiovascular exercise. Early high dose steroids right when it happens. The mixed evidence, if they help for you less, I would probably do them. I try to limit my patients on oral steroids to less than 2 bursts of that per year without really having a heart-to-heart about what other problems it could be causing. Better tolerate steroids. It kind of depends what you've had. Benadryl can sometimes help. Using them with Tylenol can sometimes help, or decreasing the dose of steroids that you're getting. So if you got prednisone, we can use Medrol. If you got Medrol, we can use half a Medrol. Steroids are bad for your bones, especially if you use them consistently and chronically over time. And then there's the X factor of the exposure to steroids you get over a lifetime. I wanted to talk about one other thing, Les, that you may be interested in. There's several of my colleagues are doing orthobiologics, which are like your own tissue injected back in. You've heard of probably like stem cells and platelet-rich plasma. There's some really good evidence that PRP, or platelet-rich plasma, which is your own blood spun down in a centrifuge and injected into those annular tears, is very, very helpful with stopping that pain. So I'll put his name in kind of the Q&A if I can. And then you can reach out to him if you like. Kyle Stoffers, he's my colleague over at Inverness. He specializes in some of these orthobiologics. Last question that I see, UCHealth have pain intervention specialists? Yes, lots of different pathways to that. I think there's lots through PM&R, which is my specialty. And then there's quite a few through anesthesia pain. So almost all of these folks are fellowship trained. The anesthesia pain folks do some of the more esoteric pain injections like base, spine, eye, etc. The spine interventionalists like myself really stay focused on spine condition. Kyphosis. So kyphosis and curve negatively impact lower back and can cause pain. So your lordosis and kyphosis. So in your spine, your neck curves that way, then your thoracic spine curves that way, and your lower back curves the other way. So that little curve in your back is called a lordosis. Kyphosis on its own, if it's normal, doesn't typically cause pain, but I think I know where you're going with it. Excess kyphosis, which would mean instead of being kind of straight like this, you're leaned forward. So when you think of maybe your grandparents, if they were really leaned over a lot, that's kyphosis. That anterior tilt puts a lot of stress on the muscles of your entire back to kind of hold you upright. Otherwise, what happens is you just kind of continue to fall forward. So it overloads some of those muscles that extend you, and it makes the ones up front really tight. So yes, excess kyphosis can impact lower back and cause pain. I like to think of it as some of that kyphosis is probably correctable, and some of it is not correctable. There are probably a few of you that have scoliosis that may have heard something similar to this. Your scoliosis is not necessarily under your control. You won't be able to straighten up a scoliosis in general, but you can prevent some of the downstream effects of it. You can work on symmetry from side to side. You can work on some of the behavioral things that go along with scoliosis. I'm going to exaggerate, but if you've got a scoliosis that causes you to tip this way, being aware that you don't, as the day goes on, lean further and further to one side and worsen some of that overload is also really useful. Scoliosis treatment, sorry, you dovetailed really nicely into the next one. I start everybody with education about scoliosis, what it is, what it isn't. I'm trying to classify what type of scoliosis you have. Did you have it as a kid? Is it in your thoracic spine up here? Is it in your lower back? Is it mixed? We work on treating the individual pain generators that happen with scoliosis. When scoliosis is really severe, meaning over about 40 degrees, or it's causing you problems with your ability to breathe or your organ function, which is super rare, we have a whole group of providers that specialize in scoliosis surgeries. At the Untitled main campus, Dr. Patel is one of them, who I mentioned a few times, and so is Dr. Berger, and so are Dr. Kleck. But more gentle and mild scoliosis, actually a really important part of that is just talking through it and kind of what you've heard over your lifetime. My experience, having seen, hundreds and hundreds of patients with scoliosis, there's a lot of bad information that people have kind of osmosed over the years. Things like if I had only braced when I was a teenager, I wouldn't have scoliosis now, or this happened because I didn't exercise enough, or any number of things. So one of the best things about these visits is just talking through and making sure you have up-to-date information about scoliosis.
Great. Thank you, Dr. Laker. It looks like we've answered all of our questions, and great questions, everyone. Thank you. So, friendly reminder, this webinar has been recorded and we'll be sending out the recording to you within the next week. Thank you again to UCHealth Highlands Ranch Hospital for giving us the opportunity to learn about back pain management from Dr. Laker. And thank you to all of those who joined us tonight. Our next virtual health event will be on Wednesday, October 4th on myths of menopause and women's health. Please check out our hrcaonline.org to register. We hope you have a great rest of your night, and thank you so much for joining.
Have a great night.